Hey everyone, we're going to discuss a subject today that you're going to use every single day of your career as a respiratory therapist. As long as you are working with patients, you will need to perfect this skill and continuously grow your ability and knowledge base to do this well and to do this quickly so that you can intervene and begin a treatment plan. And this skill is physical assessment. There's many areas of physical assessment when we are evaluating the patient. We want to look at their appearance and inspection. We lay hands on them for palpitation. We listen to them breathe for auscultation, etc. So we're going to talk about each one of those. So when we are visually inspecting the patient, we want to decide what is wrong with the patient based on their appearance. Their general appearance options are: what is their height and weight? Are they 20 pounds or more overweight, which is considered obese? Are they excessively obese, which is considered morbid obesity? We know that puts them at risk for sleep apnea, hypertension, cardiac disease, diabetes. There's lots of side effects to being obese. We need to find out what is their age and sex so we can look at what their normals would be considered. We need to find out what is their body frame, nutrition status. Are they malnourished? We see that in children that are failure to thrive, or they may have some type of absorption issue. They may have HIV or AIDS or TB. The latter stages of cancer, the patient's unable to eat as either this loss of appetite or as a side effect of the chemo and radiation. So we need to be aware of why their nutrition status seems to be less than it should be, and what their body frame is in comparison to what the normal would be based on their height and age and sex. We look at if they're cachetic. That term means they're wasted in appearance. That is a key word to tell us that they may have the diseases we just spoke of, AIDS or TB or cancer or failure to thrive. So not only do infants and children suffer failure to thrive, there are times in adult life that people with mental disorders or extreme depression may experience failure to thrive. They just don't have the motivation to do the necessities like eating, bathing, taking care of themselves. So other things we want to look at are the skin color. Are they cyanotic? Do they have blueness of the fingertips and the toes, around the mouth and nose? Are they ashen or dusky? Are they pallor? That's another key term that tells us they may be anemic. They may need a blood transfusion. If they're either of these, we need to apply oxygen. Cyanosis is definitely a key term that says there's no oxygen and perfusion normal rate, and so we need to help them with that by applying supplemental oxygen. If they're ashy or dusky, and then we may need to do the blood work to see if they are anemic, look at their CBC, look at their hemoglobin and red blood cell count to see if maybe they need a blood transfusion. If they're jaundiced or have a yellow skin color or yellowing of the what should be the whites of the eyes, then that can tell us there may be a problem with the liver, excessive bilirubin. If we see this in children, especially infants, then we can suggest the phototherapy to help correct that. And it's just like a belt that goes around the child, or it can be an enclosed, it looks like a tiny tanning bed that the child can actually be exposed to, that will help clear the excessive bilirubin. So we look for the term hyperbilirubinemia when we see a patient with yellowing of the skin or of the whites of the eyes, and that tells us that the liver is impaired for some reason. So we need to find out why. There may be redness of the skin, which is termed erythema. Erythema is a direct symptom of infection or inflammation. So we might have sometimes we get into it with a bad spider We've seen some spider bites that end up with infection and inflammation and redness around the area, allergic reactions, just anything that would cause that area to be inflamed, and what may be called angry, may have an angry area of the skin. Also, if the patient's under a lot of stress, then hypertension can cause erythema. So redness of the skin, remember, is the definition of the word erythema. Normal good color is a great sign. It means they are oxygenating okay, and we definitely want to note that as well. Not just the bad stuff, but the good as well. Chest configuration and condition. Normal AP diameter, the anterior posterior diameter, is great to see, but if we are working with COPD patients that have trapped air over a long period of time, then that's going to cause an increase in their AP diameter. Patients with emphysema, chronic bronchitis, cystic fibrosis, asthma, bronchiectasis can all have an increased AP diameter. So we need to note that. Scoliosis, kyphosis, and kyphoscoliosis are all abnormal curvatures of the spine. This can cause restrictive lung disease. When we're doing the PFT, since the patient can't stand up straight, we can't get an accurate height, so we have to measure the patient's arm span to estimate the true height. So keep that in mind. But these scoliosis, kyphosis, and kyphoscoliosis are all related to restrictive lung disorders. The patient can't get a normal volume in, and they're not going to be able to get a normal volume out, and it's going to affect their ability to ventilate well. If they're barrel chested, that's another term for increased AP diameter that we see in COPD and cystic fibrosis patients. So remember your key words. Increased AP diameter and barrel chested should automatically flag you to start thinking that the patient has obstructive lung disease, one of the COPD patients, or diseases, or a combination of more than one of them. So we want to look at the respiratory rate and pattern. Eupnea is a key word that means normal breathing pattern. Tachypnea is a breath rate over 20 per minute in an adult. Bradypnea is a breathing rate less than 8 per minute. This can also be referred to as oligopnea. oligopnea. We know pnea is the suffix for breathing, so a slower breath rate than normal is bradypnea or oligopnea. Hyperpnea is an increased rate and depth of breathing. We may associate this with metabolic disturbances like diabetes. The rhythm may be regular, but it may be just an increased rate and depth. Apnea is a complete absence of breathing, especially for 20 seconds or more. We need to get to the bottom. Anytime that we have a witnessed apneic event, we need to get to the bottom of what's causing it. Is the patient on too high an FiO2? Are they going into respiratory failure? In our infants, we see that apnea of prematurity just because their central nervous system is not matured enough to always have the baby breathe for a regular rate and rhythm, so they may have apneic events more than 20 seconds, which would flag us to initiate a care plan that includes things like caffeine citrate, which can stimulate respiration, as well as an apnea monitor. There are lots of breathing patterns that we need to know as respiratory therapists. Kussmaul's breathing is the increased rate and depth of breathing. It's an irregular rhythm that's associated with diabetic ketoacidosis or metabolic acidosis. So definitely need to learn these. They will be tested during your school year as well as on boards. Bot's breathing is an increased rate and depth of respirations. It has unpredictable periods of apnea that vary in length and frequency. It's often associated with CNS disorders, head injuries, any type of central issue. We know that the brainstem must communicate well via the phrenic nerve with the diaphragm in order to to initiate the respiratory rate. So anytime there's a problem with that, you may have any of these irregular rates and rhythms. Cheyne-Stokes is increasing and decreasing cycle of rate and rhythm of breathing. Each cycle takes up to 3 minutes to complete, but they may be as little as 30 or 40 seconds. Apnea may last up to 60 seconds in a patient with Cheyne-Stokes. This will be on probably several of your school year tests and definitely on boards. They want you to realize it's associated with ingestional errors like drug overdose and elevated intracranial pressure problems like head traumas or brain bleeds. So you may see Cheyne-Stokes in that situation. We want to look for accessory muscle use, normal muscles, the external intercostals and the diaphragm. We want to look for a nasal flaring, which relates to ventilatory difficulty, especially in the newborn. So if you have that, just increase inner diameter of the nose because they're in distress, then you definitely need to note that and initiate a care plan as soon as possible. The presence and nature of cough is very important. We want to see what is the strength of the cough, how often is the patient coughing, and what are they coughing up. So this does require us to inspect the sputum of the patient. Don't just take their word for it, but take a look. If you see frank blood, which is a lot of bright red blood, this may tell us that there's tuberculosis or there may be cancer. And that's a key word that is also associated with the term hemoptysis, which is bloody sputum. So the hemoptysis can be frank or it can be old. If it's old, it'll be a dark brown. If it's frank and new, it will be a brighter red. So this should definitely important because if the patient does have tuberculosis, you want to get them into droplet precautions as soon as possible and get them treated. Is the patient's cough dry and non-productive? If it is, think lung cancer. Again, it could be dry and non-productive at the beginning. It can change to frank blood later on, or a foreign body may have been aspirated, or an ACE inhibitor for blood pressure can also cause dry, non-productive cough. The patient may complain of a tickle in their throat, which is a side effect of an ACE inhibitor. Yellow sputum, always think inspection. Infection. Green sputum, always think infection that's been there for some time and has gotten worse. It probably started out and went from yellow to green potentially. It can be fetid, which can have a bad smell to it. We see that in bronchiectasis. It can be layered. If you put it in a sputum cup, then it's going to divide into layers, and that is always associated with bronchiectasis. We want to look at chest movement. Is the chest symmetry asymmetrical? Does one side move differently than the other? We see that in COPD, and we see it in flail chest when we have broken ribs. Maybe they've had an MVA, come in from a car accident or some other type of trauma. They may have broken ribs on one side, which is going to make the chest move asymmetrically or not the same on both sides. Pneumothorax, a collapse due to pressure on the outside of the lung. ET tube advanced too far into one lung. We know that it's typically going to go into the right lung because of just the anatomy and the angle of the left and right lung. It's easier for it to slide down into the right main stem if the ET tube is advanced too far. So we want to make sure that it is placed at 2 to 4 centimeters above the carina when we intubate. There may be significant atelectasis, which causes asymmetrical chest pattern. But the normal pattern, keep in mind, is when the thorax moves out on inspiration and the abdomen moves out on inspiration. So make sure you look for that. All right, thanks for joining us for the basics of patient evaluation and assessment. We'll definitely expand on those. So subscribe to our channel for further updates, and thanks for listening.